Hello, everyone. Thank you for joining us and welcome to the webinar on progress towards universal access to sexual and reproductive health services. What is the role of evidence in policy and program decision-making? This event is brought to you by the Department of Sexual and Reproductive Health and Research of the World Health Organization and the United Nations Special Programme of Research, Development and Research Training in Human Reproduction, together with the Applying Research to Policy and Practice for Health, or ARCH programme at the Global Health Network. My name is Ian Askew, and I work with WHO's Regional Office for Africa, where I provide guidance on the integration of SRHR within national universal health coverage and primary healthcare programs. Until December last year, I was the director of the WHO Department of Sexual and Reproductive Health and Research and director of the HRP Special Programme, where I had responsibilities for WHO's normative guidance on SRHR, the generation of evidence through research capacity strengthening, and providing global leadership on SRHR issues. I'm a social scientist by training. Before joining WHO, I was a director at the Population Council, leading its global program of implementation research to strengthen SRHR while being based in Kenya. For today's webinar, I'm joined by three panelists representing complementary yet different perspectives on using evidence for policymaking, and by colleagues from the Global Health Network team and from WHO. This webinar has been organized to address the significant challenges faced by national health systems when seeking to undertake health policy and program decision-making that is evidence-informed. Generating and translating research evidence so that it can and is used to inform policy development and policy reviews, as well as the essential functions of health systems and service delivery programs, requires clear processes and procedures, comprehensive inclusion of all stakeholders, and evidence that is easy to understand, credible, and presented so that it can influence decisions. This webinar will provide a forum for a discussion by panelists and the audience on countries' experiences with evidence-informed decision-making for policies and strategies that support the basic human right of all people to attain the highest standards of sexual and reproductive health. The discussion is expected to identify examples from various national contexts of factors that enable or inhibit the use of scientific evidence during policy making. The webinar will focus on three areas: the role of evidence from a policymaker's perspective, for which decisions is research-based evidence used and through which processes. Secondly, what relationships and processes are required for enabling and facilitating collaboration and interactions between researchers and decision makers to generate and use policy-relevant evidence. And thirdly, how civil society organizations can use research-based evidence to inform and bolster their advocacy and accountability functions. Before we begin with the panel questions and answers discussion, I just want to run through a few housekeeping items. Firstly, this session is being recorded. The recording will be shared in the coming days on the Global Health Network ARCH platforms, so you can review and share the discussion items. The link is going to be shared in the chat, so please check there so you can access it later. To interact with the panel, please use the Q&A function, which you can find in your toolbar below. If you have any technical issues, please use the chat function, and the Global Health Network team will assist you. Also, if you have general comments, please add them in the chat function, not the Q&A function. Fourthly, after introducing each panelist, I will pose a question to them about their perspective on this important issue. We've also dedicated some time later in the webinar for a Q&A from the audience, so we will try to get through as many of the questions as possible from the Q&A box. So, we're delighted to be joined by a diverse panel of experts, and we have four people talking this afternoon. First, I would like to introduce you to the speaker for today's overview session, who will provide a brief background of the issues from WHO's perspective. I'm delighted to introduce Dr. Georges Danhoundo, who is a technical officer in WHO's Department of Sexual and Reproductive Health and Research and the HRP Research Programme based in Geneva. Georges works on advancing access to sexual and reproductive health services in the context of primary health care and universal health coverage, with a focus on communicating evidence-based recommendations. Georges, over to you.
Thank you very much, Ian, for the introduction, and also many thanks to the Global Health Network for organizing the webinar. It has been a pleasure to work with you, and I hope this collaboration will not be the last one. Many thanks also to our dear participants for your time and interest in what we do. We hope to learn from each other. Next slide, please. No need to recall here that sexual and reproductive health is a global priority. And even beyond that, access to comprehensive SRH services is a critical component of universal health coverage. Next. Despite improvement in coverage, many countries are still a long way from universal coverage for most essential SRH intervention. And available services are not always of high quality. Health system dysfunctions are also major barriers. Some of these issues include the lack of transparency and participation in priority setting processes, informal payment in health facilities, inadequate referral processes, shortage and lack of competencies of providers to deliver quality services, in addition to the lack of data and capacity to use existing data in decision-making and program implementation. In response to this, our department has been using a health system approach. In fact, the families and communities that are affected by SRH issues operate in very complex social, political, and cultural environment. By taking the health system approach, we are moving beyond the silos and clinical perspective, keeping in mind that programs never come alone. A gap somewhere in a system is a limitation to the whole system. We have a range of activities, including normative guidance on SRH policies and strategies. Some of these include a UHC compendium and a handbook. Our core research and evidence building activities include the learning by sharing portal and in-depth country case studies. Let me speak briefly on some of these products. Next. The UHC compendium is a one-stop shop for healthcare interventions and resources to support UHC-related priority setting processes to ensure the integration of comprehensive SRH services in priority setting processes. Next. The Learning by Sharing portal is a repository of implementation stories documenting countries' experiences in integrating SRH within UHC. The portal is intended for national level implementers, including government, civil society organization, and academic organization advocating for SRH and UHC integration. The portal will be launched on the 19th of July. Please join if you are able. Next. Our handbook on the integration of SRH into UHC provide guidance to countries in the process of deciding which SRH services to include in national strategies and plan, and which also to include in health benefit packages, and in a practical way, how to ensure that national health systems are able to deliver these services. The handbook is intended for decision makers, researchers, and civil society organizations, and anyone working toward universal access to sexual and reproductive health in the context of primary healthcare and universal health coverage. It is really easy to read and will be launched on July the 12th. Please join also if you are able. Next. Working closely with country research teams, we conducted country case studies on the integration of SRH into UHC in Malaysia, Morocco, and Ghana. The primary objective of the country case studies is to inform the content development of the handbook. These studies are also relevant for national UHC and SRH processes. Next. To conclude, supporting countries in designing and implementing their plan and strategies and contributing to policy dialogue at global, regional, and country level is an important part of what we do at WHO. Please do not hesitate to get in touch with us if you need support. Many thanks for your attention.
Thank you very much, George, for your clear and informative background presentation. For the audience, please do post any questions or comments specifically for George in the Q&A box, and we will return to these after hearing from the three panelists. As you'll have seen in the chat already, a number of links have been provided to the various resources that George has mentioned, and so please do feel free to visit and download those. We now turn to our three panelists. And our first panelist will address the role of evidence in decision-making from a policymaker's perspective. It is my honor to introduce Dr. Sabeen Afzal, who currently serves as Deputy Director for Technical and Health Systems at the Federal Ministry of National Health Services, Regulations and Coordination in Pakistan. A medical doctor and public health specialist, Sabeen has worked with the Ministry of Health for the past 19 years. And held many key decision-making positions and portfolios, including for medical education regulations, for public health, nutrition, maternal, neonatal and child health, international health regulations, and health systems. She was instrumental in developing the National Health Vision for Pakistan in 2016-25, the Pakistan Human Resource for Health Vision 2018-30, the National Digital Health Framework, the generic UHC benefit package for Pakistan, and many other important documents. Currently, Sabeen is involved in enhancing the alignment, harmonization, and coordination of various government initiatives, including the Essential Package of Health Services for Universal Health Coverage. She has received letters of appreciation for her outstanding service from the Federal Secretary and for her contributions during the 100 days of national resolve against COVID-19. Welcome to you, Sabeen, and thank you for making the time to join us. My question to you is as follows. Sabeen, as a senior decision maker in the Pakistan government, you are heavily involved in developing policies that enable the health system to make available and deliver safe, effective, acceptable, and affordable services to meet the sexual and reproductive health needs of all people throughout the country, including those most marginalized and vulnerable in society. When reviewing and updating existing policies or developing new policies, how is scientific evidence, both from within Pakistan and from other sources, included in these decision-making processes? We look forward to hearing your answer. Over to you, Sabeen.
Thank you, Ian. And a very good afternoon, everyone, and greetings from Pakistan. And thank you, WHO and Global Health Network, for giving Pakistan this opportunity to share its experience. As you all know, Pakistan has a devolved health setup, and we have a large diversity if you go across all the provinces and the region, both geographically, ethnically, and also in socio-cultural practices. So while we choose evidence, when we look at the evidence, we look at what works what didn't work, how cost effective it is, how feasible it, giving the geography and the socioeconomic status of the people, and how what would be their acceptability given the socio-cultural and religious practices, especially when it's come to young adults and adolescent with sexual and reproductive health. What are the HR and resources available, and what capacity it is. So looking at these scenario, as a policy maker, as a government, we prefer that there is a locally available evidence is available, either from the routine data or from the various surveys that we do, like Pakistan Health Demographic Survey. We are also supported by PSLM, which is Pakistan Living Standard and Health Survey. And then there is UNICEF also performs some mixed survey, which is a district level surveys. So these are different services that we look at. But when the local data is not available, we look at the regional data. Then if even that not available, then we look at the global data or global evidence that is available. I'll give you an example of how we use an evidence and data to develop a policy document. When the DCP3 priority came up, we developed the essential health package based on DCP3. And the whole process was a very long process, especially when we were developing the generic package for Pakistan, especially for that, we did a lot of extensive work and looking at whatever the different areas for which the RMNCH related local evidence, preferably district level, then the provincial and national level evidence is available, research work is available. We collected all that data and looked at it, and where not possible, we look at the regional level research, and then we look at the global level research. And based on that, we using different available tools. In case of we use the HIP tool. We look how cost effective it is, how feasible it is, how practicable it is, and then we used it to actually prioritize our intervention from the DCP3 available interventions, and especially for RMNCH cluster. Then we developed the generic package. We presented it to the whole provinces, their health minister, secretaries, and Director General of Health, which was highly appreciated. And then they asked us to develop a localized for the provinces, because, like I say, we have a very large diversity across the country. So then we developed the local, packages. But there were many challenges. The research paper from the local level are not available. Whatever we have are from the local, very few people are able to publish, because there's a slight disconnect between the academia and the researchers and the policy maker and the people working in the field. And this disconnect, because we are more interested in the operational level or implementational research or operational research, where the academia is looking at more things. So this disconnect is there. Then there is not adequate funding available to do a robust, high quality research. Then most of the people, although do a lot of research, are not able to publish because they do not get that kind of a mentoring and capacity building to how to publish their research in a good peer review, well-rated journal, so that it can be considered. So sometimes the journal has a little bit biases, because the type of research that a policymaker or a implementer required may not be acceptable to many journals, and they are sometimes not published. So these kind of the challenges were there. So in an effort to bridge people together and to decrease this kind of, to address these challenges. What Pakistan has done is that we notified a technical working group for setting the research priorities in the health sector, and that contain a diverse group from implementer, policymaker, public sector, private sector, academia, organization that can bring in money, higher education commission that have a lot of funding for research. So these people were brought together. We chose the WHO systemic approach and guidelines for health setting priority to set up priorities in 5 major thematic areas, including reproductive and sexual health. And then we try to disseminate those priority areas to academias and professionals so that we can get research based on the requirement of an implementer and of a policymaker, because we people who are working in field sometimes disagree with what the researchers had come up. They said we do not require such kind of a research, but we need something, because and sometimes they do not have. Sometimes they're busy, sometimes they do not have the capacity, sometimes they do not have the funding to actually publish on what actually happening on the ground. So having a robust sampling and funding, these kind of issues are there. So we have tried to bridge through this forum, and we also have developed a research institute, a National Institute of Health, a whole unit of research will be looking at the health research and things that, and liaisoning with various organizations and things. We have also tried to come in contact with the grand challenges to bring in the research, especially innovative research and ideas for improving the reproductive and sexual health services in the country. So these are the different steps that a country like Pakistan has taken, given the limited resources and diversity and evolution. We're bringing all the provinces together, bringing on the same ideas and policies is a challenge in itself. Then agreeing them on the data and things another. We are currently working with the University of Washington to doing district level burden of disease, and we are working with the district managers to build in their capacity to be part of the look at the routine data, analyze them, and use them for the evidence and policy making, especially for the reproductive and sexual health. So I'll stop here, and if anybody has any question, we'll look forward to answering them. Thank you.
Well, thank you very much indeed, Sabeen, for that fascinating answer. I mean, it's really good to hear how you'd identified the challenges that you have with getting the type of evidence that you need for your decisions, and then engaging with not only academics, but also other key stakeholders to come up with a very innovative and effective solution to try to make sure that the evidence that's generated and the evidence that you are able to use is of the most helpful kind. And it was a great example to set us off with. So thank you very much indeed for that. I'd like to move now to our second panelist, who will in fact address the role of academic researchers in generating evidence to inform health policy decision-making processes. I'm very happy to introduce Professor John Ataguba, who is a health economics professor and the Canada Research Chair in Health Economics at the University of Manitoba. John is also the current Executive Director of the African Health Economics and Policy Association. Previously, he was the South African Research Chair in Health and Wealth and a Professor and Director of the Health Economics Unit at the University of Cape Town, South Africa. John holds a PhD in economics from the University of Cape Town and serves as a member of the Board of Directors for the International Health Economics Association. John was previously a Mellon Mandela Fellow at Harvard University and is a member of the World Economic Forum's Global Health Future Councils for both health and healthcare and for healthy aging and longevity. His research expertise includes health financing, health inequalities, equity in health and healthcare, social determinants of health, health economics research methodologies, and the economics of aging. So, John, thank you and welcome. My question for you is as follows. As a distinguished academic who has worked in Africa, North America, and globally, and with your focus on health economics, could you please tell us a bit about how your research has been used to inform national or global policies? What is your strategy for engaging in decision-making processes? For example, do policymakers reach out to you for evidence? Do you design research studies with policy implications in mind, or both? Thank you for joining us, and we look forward to hearing about you on these issues. Thank you. Over to you, John.
Very many thanks, Ian, and also thanks to Sabeen for setting the stage for many of the discussions. You asked kind of multiple questions. I'll try and touch through them as much as I can. The first aspect is about how my research has kind of fed into policy. I think the first thing to note for me is that you need to first of all identify an opportunity for uptake. An opportunity for uptake could come from trying to know what policymakers need answers for. And then you as a researcher, using your knowledge and expertise to find answers that policymakers can use in decision making. But it's also important to note that whilst we as academics work hard on evidence and we produce outputs, the ultimate decision lies in the decision maker. So it's important to know that the marriage between researchers, policymakers, and ultimately the people being served by policymakers happens. If that marriage is not a very well thought through process, you have the case of disconnect that Sabeen talked a lot about, that researchers are sitting somewhere else whilst policymakers are on the other side of the fence, and they are all working, hopefully working towards solving a problem for the population, and the population looking up to policymakers and everyone looking their own way. So this disconnect is something that we really need to begin to deal with. And in terms of how we as researchers can really influence policy, I would start by saying it's important for us to listen. Many times researchers don't listen. We think so much about the methods in our heads and the kind of methodological rigor that we want to bring to bear. Meanwhile, the questions that need answers are questions that require very simplistic approach to solutions to solve them. So whilst we also listen, it's important that we don't, this is a very critical point, that we don't think that policymakers are the ones who don't know and researchers are the ones that know. The answer is that everyone is knowledgeable in different aspects. It's a jigsaw puzzle. Whilst researchers might know how to feed the evidence into decision-making processes, decision makers are very knowledgeable in terms of how to navigate the political sphere and get things approved, keeping also in mind that they also have their own political inclinations. So these are very important things. And also the issue of collaboration to deal with the case of having disconnect between policymakers and researchers. What I have done in the past is to be able to use policymakers as part of a research process. And the research process should not be seen as a traditional research process where you only have researchers in a room or in a lab, but as much as possible, bring in policymakers who will be able to understand what the needs are for them. And we as researchers getting our heads thinking fast how we can help provide evidence to answer a question. So it's important that this collaboration takes place. So I've talked a lot about listening, I've talked a lot about collaboration, and also what is important. And I also mentioned that one person is not a repository of knowledge and the other one is a universal recipient of knowledge. But each person in this case, researcher or a policymaker, is knowledgeable in different aspects, and they all come together to solve a puzzle. And it's also important for us to keep in mind that as researchers, we are not all out there for research into policy. There are some researchers who are there who are working really hard on finding methods to solve problems. So whilst you find, Sabeen mentioned it, that researchers struggle either to publish work that has been done for policymakers because the research community in terms of publication wouldn't want to publish that. And I talk as an economist. It's usually the case that to get, as researchers, to get published in top economics journals, you dealing with issues that we faced in Africa, you will struggle to get such papers published in top journals. And in the end, when you want to get published there, your research is useless, as best as it could be for policymaking. Whilst it has the brownie point of you as an academic, it doesn't help you. So I think it's also something we should begin to think about in terms of revolutionizing the publishing sphere for academics, so that there will be this marriage between policymakers and researchers, and also research outlets will be willing to take research outputs that feed into policy, that really helps a large number of people in terms of population health, in terms of socioeconomic development, etc. These are issues that researchers face. So in as much as researchers try to satisfy the needs of policymakers, they also have their own objective functions and their own constraints that sometimes bedevil them. Whilst they want to help, they may also face stagnation in terms of their professional growth, etc. Now, these are many issues that are not necessarily peculiar to adolescent sexual and reproductive health, or to sexual and reproductive health, or to health of the population, but it cuts across every other aspect of research, whether you come in from a very theoretical research to a very applied research. We all have these issues to deal with. And with that, I think I would hand this over to you, Ian, and thanks also to the Global Health Network and the WHO for having me on here as a speaker. So it's a pleasure to be here. Thanks.
Well, thank you, John, very much indeed. It was really from the heart. We heard your very direct experiences, and I think a lot of what you've described here will be familiar to many of the academics in the audience and those working in research. So thank you for bringing all those points up, and also for providing some suggestions about how processes for engaging with academics can be improved. As you've seen in the chat, please do, if you're going to ask a question, if you could please put it in the Q&A box. That helps us in organizing the various questions. So thank you. Let me move on to our third panelist today, who represents civil society and will address the role that research-based evidence can play for civil society organizations when they're carrying out their mandate. I'm truly delighted to welcome and introduce Deepa Venkatachalam, who works with the Sama Resource Group for Women and Health, based in Delhi, India. Deepa's work is located at the intersection of public health, SRHR, gender and human rights, and she works through undertaking research, advocacy, and training. Deepa has been involved with the People's Health Movement in India, with the Alliance for Gender Equality in UHC, as well as with many other health and feminist initiatives and spaces. So Deepa, we're very happy and glad that you could join us today. Thank you for this. We really appreciate it. Deepa, my question for you is as follows. Through your work with Sama and your engagement with civil society more broadly to try to promote the human right for all persons to the best possible sexual and reproductive health, having access to and using high quality evidence is essential if the advocacy and accountability functions of civil society are to be effective and credible. What are the strategies used by civil society organisations to foster the best and latest evidence and to ensure that it is used in UHC and SRH decision-making processes? So thank you, Deepa, and we look forward to hearing from you. Over to you.
Thank you very much, Ian, and thank you to the organizers for this opportunity, and to Sabeen and John, who raised such important issues, and I look forward to discussing them during the Q&A. And thank you also for the introduction, Ian. I just wanted to reiterate that SAMA, the organization that I am with, works through building capacities of multiple actors, building evidence for advocacy through research, mainly through qualitative research, and through creating and disseminating knowledge resources based on the evidence. All of these are very core and interlinked strategies to forging shifts in health policy and fostering accountability. At least that's what we believe. Evidence to inform policy and public advocacy processes on SRHR has been very critical and central to our work. That we have been doing this for over 2 decades. How do we use the evidence for SRHR, for sexual and reproductive health and rights? We build and use evidence in varied ways. Firstly, evidence we feel often provides a very homogeneous picture. This is not always, but often does. It often ignores marginalization or the experiences and realities of marginalized communities such as tribals, queer, trans communities, communities with disabilities, of marginalized geographies, very remote or rural geographies, or marginalized issues within the public systems, be it, say, infertility or gender-based violence or abortion. So we really feel that it's very important while building evidence to interrogate and challenge this homogeneity and build evidence that draws attention to this marginalization and the implications for sexual and reproductive health and rights. For example, the evidence from our research that we conducted a few years ago before COVID on the status of healthcare for tribal communities foregrounded often invisible kind of health concerns. Not like it's not known, but it's not visible enough for it to garner healthcare services. So health concerns that are endemic to these communities, like sickle cell anemia or thalassemia, which have grave implications for sexual and reproductive health. Secondly, we use the evidence to amplify the issues, that is to keep them live, to provide insight into current ground realities in changing contexts, because contexts are constantly changing. There are newer challenges, both politically or economically and socially, and we've seen that during the pandemic. And assess whether there are any improvements, there are any shifts, or for the better, or have things worsened. So evidence around all of this, we feel, is also something that that is very important to do, and we keep doing that. Thirdly, evidence and advocacy do not always, according to us or in our experience, follow linear pathways. For instance, advocacy processes may determine the need for evidence building. Too, it may throw up opportunities for collaborative processes, and I think John mentioned that too, that may be extremely significant. For example, it's not as if evidence on SRHR did not exist before some of the work that we've done. We've done research on SRHR quite extensively. And recently, 2-3 years ago, we did a country assessment on sexual and reproductive health rights. However, the collaborative process involved 2 CSOs, 2 civil society organizations, including SAMA, along with the National Human Rights Commission in India, which is a quasi-state institution. And this provided leverage to the evidence and to the process that allowed, updates in SRHR policy, legal reforms, and program implementation context in the country. And it allowed us to take recommendations to policy quite directly. Finally, I just want to say that, I have some more to say, but in terms of how we use evidence, I just want to say that we also use evidence on a very regular basis. And I think Ian and John had flagged this. to assess implementation of policy programs, to assess quality of care or equity in access, on innovative practices. And we've done this by conducting research in under-researched issues like assisted reproductive technologies, surrogacy, on mental health. We also use research to really flag innovative practices that policies across countries can learn from across, especially in particular regions. We also feel that fact findings, although it's not considered research, but it's worked very well for us to garner evidence for policy, which is pretty much rapid assessments, where there are denials or violations of sexual and reproductive health rights that necessitates urgent evidence, to address the denials. So this is something we've done in the context of maternal deaths or sterilization deaths or unethical trials, clinical trials of the HPV vaccine on girls from marginalized communities. So summing up, I just want to mention some few strategies that have helped us foster the use of evidence for sexual and reproductive health rights and for accountability. I think one of the things that I mentioned earlier is strategic collaborative research that provides spaces to amplify the evidence, whether it is with quasi-state or state institutions or academic institutions. And this also helps us to translate evidence to policy more effectively. Dissemination and building an understanding of evidence amongst peer organizations is also something that we think is very important to mobilize more widely for advocating the evidence and to bringing about shifts in policy. Assessing gaps in evidence along with communities, CSOs, and facilitating their involvement in the process of building evidence and its dissemination and advocacy is also very critical according to us. We also feel that evidence as a peg around which multiple actions at multiple levels are planned must be done as a sustained and long-term kind of a process, because as we know, evidence does not very immediately and easily lead to policy change, and processes take a very long time. So this is what I'd like to say as I sum up. And my last point would be that there are some challenges, some very critical challenges ahead of us and have remained with us. I think John flagged one of them, which is about political will. As good as our evidence might be, as robust as it might be, if there is no political will, or what Sabeen said, if there's a disconnect about what policymakers require and what research is being done, I think then the translation of evidence to policy and shifts is very challenging. Finally, I think this is something that we keep talking about: what really constitutes evidence? Who decides, or what decides the agenda for evidence building, and who is typically involved in these processes? These are not exactly challenges, but I think these are questions that we really need to discuss further. So with that, I kind of stop here and over to you, Ian, and happy to respond to any questions.
Thank you very much indeed, Deepa, for your answers there, and really some great insights into how evidence can and is used by your own organisation, but civil society more generally. So thank you both for the specific examples, but also for the more general information about civil society generally. Before we move on to addressing the questions being posed in the Q&A, I've got a question which I'd like to pose to all three of the panelists and to hear their answers. It's a bit of a selfish question because it refers to, and it's about the role of WHO and how WHO could do its job better with strong evidence from research. So I just wanted to sort of put across the perspective that WHO has the global mandate to develop evidence-based normative guidance for sexual and reproductive health and rights. To do this effectively and efficiently, WHO has a standardized process for guideline development. This process seeks to both respond to requests for new or updated guidance from countries, as well as to collate, synthesize, and interpret the strongest evidence to inform the recommendations that WHO then makes to countries. Health ministries, academic researchers, civil society all have critical roles to play in this process, helping WHO to identify which guidelines need to be updated or to be generated from scratch. How can these recommendations be developed for countries? And as critical actors in countries yourselves and in regions, to help in the effective uptake of WHO's recommendations in national and organizational policies. So from a quick question for all of you, from your perspectives, do you have any suggestions for how WHO could better collate and use the evidence available? And what can WHO do to ensure that research is undertaken so that it does generate evidence that can be used for informing the global guidelines that we need to produce? So that's my question, looking for some help from you, from your experience. Maybe we start with John, perhaps you could go first.
Many thanks there, Ian. Like I said, it's double-barreled or multi-barreled question. I would stab it from one side and I'll pass it on to colleagues. How can WHO one collate evidence? There are many ways. One thing that really strikes me is the fact that we keep repeating the same thing over and over again in a different guise. We should, as a matter of urgency, learn from what we have done before, see where challenges are, and try and perfect that, rather than moving on to something else and something else. I'll try and explain. So if we already know that something works, we should try as much as possible to make sure that thing is put into use, respecting, very importantly, respecting differences within contexts. Many international organizations, not just WHO, over the couple of years, apart from now that things are kind of shifting, tend to have this one-size-fits-all approach. But of late, there's been this move to move beyond having a one-size-fits-all, to begin to recognize the differences within countries and even between countries. A policy that works in Ghana may not work in Burkina Faso, even though they're neighboring countries. A policy that works in Kenya may work in Morocco, even though they are far apart. So it's important to keep in mind that collating evidence is good, but in itself, it may not translate into policy if it doesn't really fit the context. Oftentimes what is done is that evidence is collated through some sort of mapping of countries. This is a low middle income country. This is a country in transition. This is a country in war. This is a country in blah, 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 different categories. But such categories don't necessarily work in many countries. A country might be a country in war, but you cannot take policies that work in another country in war and then move it into that country. So the typologies we use, we should begin to think about that. So when we collect evidence, we should go beyond such categorization to say, well, these are different countries. So you look at it, depending on what country you're coming from, and then you figure out which of the boxes in the typology fits you, and then you take policy from that and you apply. It may not work. It may even mean that you go into the other box in the typology that doesn't even fit your categorization and it works. So it's important, therefore, that in collecting evidence for policymakers, especially as WHO goes to countries and support countries, that it really is embedded within the cultures, the context, and the richness of the country. And also keeping in mind the diversity, even within countries. There is no homogeneity in countries. Many countries are as diverse as possible. So that's one way. And also, I will quickly add that in many countries, many countries know what the issues are. They know what the solutions are, but their hands are tied. How do we untie their hands? I'm speaking metaphorically. How do we untie their hands? Hands are tied sometimes because of finances. Sometimes their hands are tied not because they don't know what to do, but because the political sphere is not right to do it. Even though we know evidence suggests that that should be done, the political sphere is not willing to accept that that needs to be done. So these are the kind of software issues that we should begin to deal with, rather than the hardcore evidence that researchers are good at doing and churning out papers. For example, I would hand this over to the next. Thanks so much, Ian. Pleasure.
Oh, thank you very much indeed, John. A very, very helpful answer. Sabeen, I'm sure you've been involved with or responsible for adapting the WHO guidelines in Pakistan in various ways. Any thoughts from yourself about what could be done better, or are the processes going well so far? Over to you.
I agree lot of the points that John has raised. Most important them in the context. I think I have been part of when we were updating IMNCI guidelines in Pakistan. And I just realized that, as the new evidence come up, WHO make a generic document that's fit for 194 member states. Then I think what the country office, I think what John has also highlighted, as a country office and as a regional office and then HQ, what they should support the countries to customize to their needs, to their local context. Like, for example, when I was talking about the UHC package, when we developed the UHC benefit package, we developed a generic, or you can say national document. But then we realized that when we go into the districts, into the provinces, there were different political governments, different political agendas, and different terrain, weather condition, ethnicity, languages, socio-cultural practices, eating practices, health-seeking behaviors, education level, poverty level. So there were so many things that we had to take care of. So if you take specifically Pakistan, things that may work in Punjab, which is a very highly populated province, may not work in Balochistan because the population is very small, the geography is very large, and to walk from one district, from one place to other, it takes 20-30 miles to reach to a next population. So if you say one vaccinator per district, might work in Punjab, 2 district vaccinator, but may not work in Karachi, because Karachi itself is a city, but it within its city you can at least fit 10 or 20 countries. So it's more than it's a 20 million population of that city itself. So it's a metropolitan. So you cannot say just 2 vaccinator for one city. So you have to look at that context when you are looking at these kind of aspects. Then especially, so I think my suggestion would be that how WHO can help. They can customize things. They should help the countries to develop a generic, a national level document, and then specific to those provinces or sometimes district level documents, because things are happening, the actual things are happening at the district level, at the union council level, and we have to look at those realities and those things. Like Deepa said, sometimes things are there but they are not visible because they are happening to a very small segment of the society. But as a healthcare provider, as a policy maker, as a government, we have to reach those people as well. And sometimes government cannot reach there. So they had to have whole handling with the private sector, sometimes with profit, sometimes without profit, the CSOs, the NGOs that are working there. So these things. And to be very honest, they keep sending us a lot of surveys. And when we send it to the district, they actually to be with due respect to WHO, they find it sometimes cumbersome filling same information through the various aspects. Once we were there is there is a score data, there's PHMSI data, then there are regular DHIS data, then there are and they keep asking you for various things to be add on into things. So sometimes there is a human resource constraint, and then there are not many people available for just entering the data. So people sometimes find, so just collating data won't help. Like John said, we have to look at the context and then help the countries to develop things and policies and research as per the context of the country. Thank you.
Thank you very much indeed, Sabeen. Very, very helpful indeed, certainly from a WHO perspective. But I think also part of what you're saying reflects, and I can see other people nodding here, that what you're describing is not unique to Pakistan, but is an issue faced in all countries trying to adapt the WHO guidelines. They are intended to be global, but then at the regional, country, and district levels, there are a lot of challenges there. Deepa, over to you, but I'd like to just twist my question a little bit specifically because of you representing civil society. I've been involved in a lot of WHO guidelines, and one of the challenges we constantly face is trying to get the full range of inclusion from civil society, because there isn't one civil society, and particularly in sexual and reproductive health, you get different groups representing different populations, different people, different needs. It's quite a challenge from WHO's perspective to try to make sure that we're being as inclusive as possible and not missing out key groups that could really help to inform a WHO guideline. And, particularly when you put that on a global basis. So I don't know, as someone from civil society, any thoughts on how WHO could do that better, more efficiently, more representationally? Over to you.
Well, I think what you just asked me resonates with some of the points that were already raised by Sabeen and John. I think within countries, there are countries and nations within nations, and like so much of diversity, and it is challenging, even for civil society to ensure that kind of inclusion. But I think some strategies that work are one, to really see if regional offices or country offices could play a more proactive role in really facilitating processes, and I think there is a very vibrant civil society, whether it's in India or Pakistan or wherever you are. I am sure there is a lot happening, and ways in which we could collaborate to ensure, whether it is academia or whether it's civil society, other activists, or along with or researchers or policymakers, to really come together to deliberate on some of these things as to how evidence can be used, what are the barriers to using evidence, or as Sabeen said, and I agree with both Sabeen and John, that how do we ensure, of course, WHO guidelines are generic because they are made globally, but how I still think there is merit in them, because I've used some of those guidelines, and how we adapt them to our countries. I think at that level, we still need some support and some kind of, understanding, or some kind of a process of facilitation that brings together all of these different groups, so that there's more inclusion. There's also a representation of issues or concerns vis-a-vis any of those guidelines, whether it is by WHO or whether it comes to the country level and is being adapted there. So I think mine's a very generic answer, but what I mean is that this is not an easy thing, but it's been done and it can be done. But I think that it needs to be therefore more decentralized as a process. And I think one of the other points I wanted to say is there needs to be better access to say collation of evidence. So, if WHO is collating evidence, has the wherewithal to do it from all over the world. How do we make it more accessible? So it's not just say Sama, I'm representing Sama, but I'm a particular kind of organization, like you said, Ian, and there are organizations and organizations. So how do we really bridge that gap? And I think that's I guess for another webinar and or for us to discuss it further, but I just wanted to flag it here. Thanks a lot.
Thank you to Deepa for that great answer. I think if I was to summarize all three responses from the panelists, I think they all focused on the issue that global guidelines are good, useful if the process is followed well, but each country does need to look at it from its own perspective and feel free to adapt it to the nuances of a particular situation at subnational level, particularly, or the national level in relation to the differences with the global areas. Bearing in mind that the original recommendations are based on the best evidence available globally. And so it's important not to stray too far from the recommendations themselves, otherwise they would no longer be following the evidence that they're based on. But as someone who's recently moved from WHO headquarters to the regional office for Africa, I hear your comments very strongly. It's certainly a situation that we face on a daily basis here in the African region, given the diversity of countries and situations within the region. So thank you very much indeed for that. We have about 20-25 minutes left in the session. And so I'd now like to move on to addressing the great questions that we have received from participants, which are in the Q&A. Some of these have already been responded to in writing by some of the panelists. So I'll start with the more open ones, and just what I'll try and do is direct the question towards one of the panelists and ask that panelist to respond to that question. And then if other panelists would like to also answer that question, you can feel free to. But just to sort of keep the flow moving, we'll go with one panelist at a time. So let me take the first question. I'll just translate it a little bit. One of the questions here is around the issue of if you like, the role of translating research results from research to policy decisions. And the question is this what we consider to be implementation science or implementation research? Is that where it falls? So maybe, John, I think you might be the first person to answer that, or the most appropriate given your academic background. Is what we've been discussing today, is this what we call implementation science, implementation research, or is it something else? Over to you, John.
Many thanks, Ian. I speak as a health economist, not as an implementation science expert. But to answer your question quickly, Uzma, I think, in a way, yes, because it's all about moving research to policy and keeping in mind context and what makes something work and what are the things that make a particular policy not to work in a certain context, and trying to navigate things to make sure that you allow it to work. That's the whole idea behind implementation and science. So you need to learn how you can apply something, and where it doesn't work, how do you make it work? And that's pretty much what, my own opinion, what we've been discussing here, is how do we make sure that research moves from the desk where we do our work, or the lab where we work, or the field where we collect data, to real implementation, that is it being taken up by policymakers, and ultimately it translates into good health, good public health for the population. That's pretty much it. And keeping in mind also the importance of political engagement. If policy needs to work, there needs to be active engagement with the population as well, because you cannot make policy without keeping in mind the people. I would stop there. Thanks.
Well, thank you, John. Very, very helpful indeed. Thank you. I think the next question, maybe I'll direct it towards Sabeen. It's from someone called Uzma Alam. And this question is asking about what can be done to drive national investments in this science policy engagement. Is there something, maybe you've got an example already from Pakistan, or is there something more that could be done to try to get investments in strengthening the engagement of science and policy together? Sabeen, any thoughts on this?
Well, to be honest, it has been a challenge. As a health ministry, requesting or allocating funds exclusively for research in a very limited resource setting, it becomes a huge challenge. Then I think sometimes you have to look at other avenues as well. For example, in Pakistan, the Higher Education Commission has funds available for research. And they give research to researchers who have a team, which include one of the ministries and someone from the industry as well. So that if something like somebody has developed something and it works in that research, then the industry can help them to, fund it to begin with. And then if you want to expand its funding or expand its production, then industry can take it and a locally produced something can come up. So so we actually work in close coordination with the Higher Education Commission. They have different level of funding, small grants, then large 3 to 5 year grants where researchers can do. So this is something that done. This is one thing that people can look at how the money can come in. Then Higher Education Commission also give money to all the universities and degree awarding bodies. So people, we encourage people in public health universities and in the medical universities, so to get grants from them and then do research as per priority setting that government requires, or as a policymaker we require. So this kind of but it's more of a struggle. I would admit that bringing people together and making them sit together and then making them work together, because sometimes as a student people like to do a research that they are more focusing on getting their degree, but after getting their degree they are more focused on getting a lot of publications. So doing something that may not publish, people are not that much interested in. So it's a struggle, but this is one way of doing it. Then you can always get some funding from a certain organization, like I said, Grand Challenges Global is another area that had worked with governments where they provide funding available for them. So we have to look on, we have the Drug Regulatory Authority of Pakistan also have a lot of funds available for research, but their focus is more on drugs and pharmaceutical and things. So just find people who have money and pot of money available, work with them. So you have to bring all the three entities together and then think. Otherwise, if you exclusively said that the health ministry would get money for research, well, that's that would be a very difficult process to do it. I'll stop here. Thank you.
Thank you very much indeed, Sabeen. Very many suggestions, which, although you're drawing them from Pakistan, I think they apply to many countries. And I think also just to, you mentioned looking externally, but I think really we need to find ways of mobilizing national investments from national treasuries and so on. That way, countries will recognize and own the importance of evidence if they're supporting its generation and engaging their own researchers in this. The next question, I think, is probably best addressed by Deepa. It's a question from Catherine Otieno. And she's asking about strategies for research feedback to the community. What can be done to help ensure that the research is fed back to the community and is useful to community members and adapting and improving their lives. Deepa, do you want to try that question?
Yeah, thank you, Ian, and thank you, Catherine. So just a couple of examples. I think we don't have too much time, but just a couple of examples of doing that. I had mentioned during my presentation or my, when I was talking earlier, that involving communities in actually developing or identifying areas for research is a very good place to start. And if you have a long-term relationship with certain communities, or even if you don't, there could be processes that allow you to do that, which are through organizations or, along with other civil society to really identify what really needs to be done. Or what are the areas, say in SRHR, I said there are issues that were extremely marginalized, not visible amongst communities, and which are very important for, say, health services. So one is that, but the other thing is about taking back the evidence that's emerging from research. And I think that is being done through multiple ways. One is through actually going back to communities where the research has been done for dissemination. So of course, that would mean that all research products or outputs from research are developed in languages, in formats. So if you have that are accessible. So for example, if there is research happening with communities with disabilities, how do you ensure that that information, that evidence goes back to them and is accessible to them to use for advocacy or to use in any which way they would like to do that? So there are processes that I think, many of us have been trying to build into a research. So when we say research, it's part of that is also about really understanding whether this is an area that is critical to be understood or researched in a particular context, and then also to see how that output or evidence or knowledge goes back to communities, both at the grassroots, but also at the national or subnational levels through dissemination via various formats. I mean, that those can be thought of based on wherever one is located, but it's very critical to be part of the research plan, I think. Yeah.
Oh, thank you very much, Deepa. Thank you for that. And yeah, it is a tricky area, and the communities that, as you say, both provide the evidence through the research are often left out of it and don't get to hear the results. And so it is critically important to try to include them in the research processes. The next question, I think, probably goes to both Sabeen and John. It's from Yvonne Tumasang. Yvonne says that collaboration keeps coming up as a key, but then specifically she refers to policymakers. How can we effectively involve policymakers in research? So maybe, or should we involve policymakers in research? Maybe we should put the question that way around. Should we, and if so, how? So Sabeen, as a policymaker first, would you like to answer? Then John, as a researcher, would you like to answer? Over.
I think we are involved, at least I can say for myself, although we do, being so busy, actually writing a decent paper becomes a difficult thing. But I think involving policy makers in the sense that we can get guidance and directions from them, and then we can go ahead with the research. Because all people who do their masters or PhDs, they do write a dissertation. People who do fellowship in medical clinical side, they do write a dissertation. Same goes for people who are doing in public health. So I think what, as a policy maker, what we should do is that we can sit with these organizations, like we have a technical working group and we have prioritized areas we shared with them. So, okay, when you next time your students come up, kindly look at these areas. This is the areas we would like you to do research. We have give you a broader area, maybe you can come up with it. And you can always involve health ministry for, people do come us when they want to be part of some data collection or from interviews and things like that. So these kind of involvement should be continuously there. And we should also encourage people, some, I don't know how to say it. Technical people are very supportive of, research and publication. Bureaucratic people are not. And I think we have to, one reason is this, that I don't know about other countries, but probably Deepa may understand. India has a similar sort of a setup. Your secretary, maybe your secretary, a health secretary, and after a year or so, he may be working in forestry or maybe in municipality. So he's not that much interested in doing a research or part of the policy. He will be more interested as long as he's holding that job. So, so I think if you can just involve the technical people, and then they can convey it to their, higher ups, that actually, help converting those evidence into, policies. And then policies can also, requirement of the policymaker can also go to the, academia. So one purpose of developing that technical working group is the same, that the CSOs, the academia, the private sector, both from the clinical side as well as the public health side. Because when, as a public health professional, we have a bias, we bring in the public health profession, we forget the clinical people sitting in the hospitals, because whatever they are doing, we have to, because sometimes they don't understand, okay, there is a health policy. If you ask any of your professor of any university who's the head of the cardiology or surgical department, he may least concerned, but if you ask him about the surgery and the later procedure, he'll tell you. So we have to engage these people as well, because they have students, they can mentor things, they can be help people write research paper, help them publish research paper, and they actually deal with public. The community, people are coming to them. So if they are doing, taking care of a clinical aspect, at the same time, when the patient is leaving, they can advise them to do the public health side, the preventive health side as well. So this is how, a policymaker can be involved in both ways, by giving guidance as well as using the available evidence. Thank you.
Great answer, Sabeen. Thank you very much. John, any perspectives from academia?
Yes, very many thanks, Sabeen. I think you kind of set the stage again here. I would start by saying that research is a process, it's a journey. Because research is a process and a journey, it doesn't stop anyone from being part of that journey, including the community, civil society, policymakers, researchers, people in any sphere of life can be part of a research process or research journey. To make policymakers involved in research is like saying that they've never been involved. I think what we could say, I like the way Yvonne put it there, effectively. They've been involved, but perhaps passively. One thing I'll keep saying is incentive compatibility. Researchers have different incentive systems, why they want to go into research. Policymakers have a different incentive. If these two incentives are not compatible, you will always have this tension and disconnect between the two. So research, starting from the identification of a problem, has to work hand in hand with policymakers, because for you to identify the problem, which is the birth of a research agenda, you need both policymakers and researchers to come together to figure out what will be compatible to two of them. If the problem is compatible to two of them, the solution will most likely be something that will be mutually respected. Down to the output, I'll just skip the intermediate, down to the output. When you get to the output, there are many outputs from a research. It's not just research publications in leading journals. There are policy briefs, there are guidance notes, you can mention many of them that can come out of a research. And policymakers might be interested in a policy brief, for example, as opposed to a research output that is in a journal, but the researcher will be benefiting from a research output in a journal. So this incentive compatibility that in the end, everyone gets what they want and the outcome is improvement in population health is what we need to push. Thank you.
Thank you so much, John. We have just about 5-6 minutes left. Before we go to the closing remarks from our organizers, Deepa, I have one quick question for you that's in the chat. If you could just answer it in a minute or so. And it's about gaining political support for implementation of research findings. I'm sure as a civil society advocate, you've had a lot of engagement with politicians, hopefully positively and maybe negatively, but any thoughts on how to best get political support for implementing the research findings that we've been talking about? Over.
Well, that's a tough one, but yeah, I just want to say that yes, there have been positive and not so positive kind of relationships or interface with with the policy makers. But I think that is somewhere rooted in what was said earlier by Sabeen and John as to how, and in the context of collaboration, as to whose agenda that research is and what is really required to be done. And I think if that kind of a collaboration or an understanding is, I mean, it's a mutual understanding, it's felt that it's a need of all actors involved, I think then there is a possibly higher possibility of that evidence translating to policy. Having said that, I also feel that there needs to be an institutionalizing of some processes where research findings and evidence, I mean, there should be some commitment on the part of policymakers or institutions to say that, yes, this research has been done and we've agreed to this research, and therefore the recommendations or the, the findings, evidence that's coming out of this is something that we will at least give due consideration and set it up for a discussion or wider deliberation to see how it can be translated into policy or program or whatever else that needs to be done. So yes, to keep it short.
Thank you very much, Deepa. Thank you indeed. And thanks to the panelists. Thanks for the many questions put in there. And as you heard, they were very good questions because they generated very good answers too. Just for the last few minutes before we wrap up, I'd like to hand over to the organizers of this webinar and to provide a few closing words. First, I'll hand to Dr. Veloshnee Govender, my colleague from WHO. Veloshnee works in the Department of Sexual and Reproductive Health and Research alongside Georges. And then after that, we'll conclude with Frank Igoro from the Global Health Network. So, Veloshnee, over to you.
Thanks, Ian. Can you hear me clearly? This is the first time I'm using headphones. I'm just making sure that I can be heard, and I will try and speak slowly because I do have a tendency to speak quite fast. I think, in a few minutes that we have, I think we need another webinar because my closing remarks really cannot do justice to the richness of the experiences that we've heard from our panel, as well as the questions from the participants. But one of the key learnings, I think, that's come out for me from this discussion, well, a couple of things. I mean, the first, I think, was a remark from John about research being like a journey. And then I was reminded of the African proverb, which goes, and I'll read that out to you. If you want to go fast, go alone. If you want to go far, go together. And I think our panel has spoken very clearly and eloquently, passionately about the importance of collaborations, about partnerships. And I think Deepa has spoken, especially importantly, about the role of civil society, but also the importance of community voices, marginalized populations, marginalized geographies, and the importance of engaging those of communities as research partners, not only in shaping the research agenda, but in a truly participatory way, ensuring that their voices are included. I think we've also listened. I think we've, from WHO side, I think it's really important that to get the feedback that we have received from our panel members. Sabeen, we hear you about the overload of surveys and the frustration of country offices and ministries of health. And I think that is something that we are very much aware of, and we will certainly communicate that back. It's not the first time, but we do promise that we will try and pay heed to that. I think we've also heard the importance of adapting guidelines. And I think, as Ian has reminded us, guidelines that WHO takes lead on developing are very much, goes through a very rigorous process. And before being published, is very much informed by the rigor or the availability of evidence. And the question then rests, how do we adapt that at country level? And I think the question also came from probably the audience about the importance of implementation research. I think we cannot underscore how important and relevant that is. We have the guidelines, and as we know, guidelines are generic, they're global. But how do we implement that in practice? How does that inform policy? How does that inform program implementation on the ground? And that's really the importance of implementation research, operational research, implementation science, if you like. But the point being is that we also need, and I think Sabeen also spoke about the importance of research capacity at country level. Being able to invest in research capacity. I think Ian also noted the importance of countries themselves taking the lead, taking the leadership in recognizing that research and evidence is critically important and allocating and earmarking domestic resources for that. And finally, I think I think there's so many important points. I'm not going to say one of the most important, but an important point that was also raised is, what is research and what are the different types of research? Deepa mentioned rapid assessments. And I think we would all agree that if we think of research and evidence along a continuum, there's that which is anecdotal, and then that which ends along the continuum as that we would inform our guidelines through systematic reviews, randomized control trials, the more the gold standard. But rapid assessments, which also try to understand the impact and inform policy, inform program, and for policy or programs to be responsive on the ground. And I think this was particularly important, what we saw during COVID, is the role of rapid assessments. So I think there's certainly room for us to think about how we imagine what research and evidence is, and to be much more open in terms of what we consider, and particularly also strengthening and engaging the role of civil society as well as communities. And on that, I think I have probably another 2 pages of points that I could run through, but I will stop. And just to thank our panel and the organizers and Ian for the facilitation. Ian, over back to you. Thank you.
Thank you very much indeed, Veloshnee. I'll just now hand over to our partners in the organizing this, the Global Health Network, and leave it to Frank Gregor to round us off for this session. Thank you, everyone, for listening in, and panelists. And over to you, Frank. Thank you.
Thank you, Ian, and all the colleagues for this great event. And us at the Global Health Network, we're just a community of practice, and our aim is to help health research to cross boundaries by sharing the know-how, excellence, and enable more and the better evidence generation. And on that same mark, I would like to invite you all to the Global Health Network Conference of 2022. And this will be in Cape Town in November. So while we want to still pick up all the notes that Veloshnee still has on our notebook, and or what we haven't said, we can meet in person and discuss this further. So kindly register. We will have plenary sessions, symposia, and a lot of collaborators will come from all over the globe. Thank you everyone for attending, and this will mark the end of our webinar, and welcome again to the next ones. Thank you.